Hey everyone, thanks for joining us. I'm Jay from the Human Diagnosis Project, and I have two fantastic people with us today to speak about some of the work that we're doing to hopefully help the uninsured of America receive specialty care. So we have one of the world's leading experts in medical education here, Vinny Arora. We also have a gentleman who has now joined our team, Dr. Seiji Hayashi, who is very involved with providing care to the underserved throughout his career. He was previously the Chief Medical Officer of the Health Resources and Services Administration, which is a $5 billion federal agency that's helped provide care to tens of millions of people. I'd love for each of you to just briefly introduce yourselves, talk briefly about your career, and then we can, of course, get into questions.
Great, thank you. So my name is Seiji Hayashi. I'm a family doctor. I've been practicing in the safety net and federally qualified health centers for close to 20 years now. And I've had a varied career, but been always interested in how do we make diagnosis more accurate and treatment more accurate and accessible to our patients, especially vulnerable patients. And so it's taken me through academia, it's taken me through government, but all the while I've been practicing in an FQHC seeing patients.
Fantastic. And we're super excited to now have Dr. Hayashi on our team. It's really an honor to have him as a member of the organization now that hopefully can help bring this care to people who need it throughout the U.S. Vinny?
Hi, I'm Vinny Arora, and I'm a hospitalist here at the University of Chicago, and I take a special interest in improving medical education, particularly with respect to quality and safety and value. I also have a master's in public policy, and so take a high-level interest in making sure that the residents and students that we train, the future doctors of America, are serving our nation's health needs.
Absolutely, and I think one of the reasons we were so excited to chat with Vinny during the early stages of our work is because of how much she's looked at small kind of bite-sized or incremental learning as opposed to kind of long tests. Would love for you to just briefly speak about that because that clearly overlaps a lot with the work that we're doing here.
Yeah, that's really important. And so thinking about adult learning theory and how do we train our doctors to learn, that's a question that I think a lot about as a board member now of the American Board of Internal Medicine. One of the things we know is that doctors are learning every day on the job and when they're seeing patients. And so whatever we do, whatever we're asking them to do to continue to keep up and learn as well as improve the care of their patients, it has to fit into the workflow of their day. And so that's where I'm really excited about the possibility of using things like technology and mobile platforms, because I think something that's really ubiquitous that doctors love is their smartphone. And if we can empower them through their smartphone to take better care of their patients and also keep up and learn, it's a win-win.
Absolutely. One of the things that we're thrilled about is that we have the opportunity to get advice from people like Vinny about how to design the system such that physicians around the country and ultimately the world can benefit from such a system and improve their skills while simultaneously satisfying requirements that they already have, like continuing medical education, maintenance of certification, etc. And so we're really thrilled to have Vinny involved in terms of her input and advice, as well as a contributor to Human DX. So that's really fantastic. Well, before we continue, I'd love to kind of just briefly speak about the project and the opportunity to potentially work with the MacArthur Foundation to help bring specialist care to the nation's underserved. We're honored to be considered one of the 8 semifinalists for the MacArthur Foundation 100 and Change competition. It's really an honor, and we think that there could not be a more critical problem at a more critical time than what's happening in the US today. As we know, there's already tens of millions of Americans who are uninsured. Depending on how policy changes play out over the next several months to years, it could be well more than that. We also know that there are tens of millions of people who are underinsured. And in addition to that, if you take all of the underserved populations in this country, I mean, we're approaching close to a third of the country. I mean, it's really kind of staggering and shocking as one of the most well-off countries in the world that this is something that we're still kind of grappling with as a society. And we think that this has the opportunity to be a tremendous source of essentially change to such a system by developing a national electronic consult system enhanced with artificial intelligence to expand physician access to these patients all over the country and ultimately the world. We are very excited about the way we've built this technology because in addition to being able to provide specialist insight, it also has the ability, as we discussed, to help educate, train, license, certify physicians. So it allows them to take advantage of something they already do every day. Seiji and Vinny, I know Seiji, you've been working on some ideas around that in peer review and other requirements that are necessary for physicians. Would love for you both to talk about how could that actually help you as physicians to actually just take care of some of the the burdens that you have to kind of do in terms of day-to-day work.
Sure. I think that the medical education use cases are very important, and we as physicians, we're always trying to learn, and that's really important. But those of us, who work in the safety net, the thing that weighs us down is when we don't have the ability to really help our patients. And that may be because our patients don't have insurance and they may not be able to pay for their laboratory tests, their medications, and especially going to see a specialist. And in that kind of situation, we feel like we failed. And by having a technology like this where we can electronically and remotely, virtually access specialty care, it would really help us. And not only does it take off stress from the providers, but obviously it's helping the patients. And for a patient to be able to access care without worrying about insurance status or without worrying about putting their kid into daycare, or losing their pay because they have to take time off from work, all those things are such important aspects of care in the safety net. And so a technology like this would be a godsend for all of us.
Fantastic. And Vinny, I'd love to hear your perspective more from the physician side. How could this be useful to both primary care physicians and specialists in terms of both learning and dealing with ongoing requirements, given some of the things we've discussed?
Yeah, so we know that physicians are basically under siege from administrative work, and that's probably putting it lightly. And
that
so,
right there.
Yes, and so we really, really need to be very thoughtful about the best ways to engage our physicians so that they can not only provide the best care for patients, but also do it in a way that they're not harming their own personal self-fulfillment, because our job as medical educators is to keep them in practice as long as possible so that they can deliver the right care to the right patient at the right time. And so, I think that's where a platform like this comes in, because one, it fits into your workday. It's something you can kind of do, at any point, and it sort of respects the natural workflow. But also, doctors love talking to each other. We're very collaborative creatures, right? You go into the resident workroom, we bounce cases off each other all the time. And so if you're out there in the safety net, Seiji, like by yourself, it can be sort of lonely, because we know we're a health profession shortage areas all over the country, like here on the south side of Chicago. So this is a great virtual workroom, if you will, where he could bounce a case off a specialist, and a specialist who actually has expertise, who wants to provide that expertise, but is constrained by the current workflow that they have to provide it. So I think it's a great win-win, and given all of the extra things doctors have to do to keep up, as well as document, we are looking actively for ways to double and triple count. So I know that already by giving CME, that's a huge win, and I know there's explorations underway for maintenance of certification, which I'm really excited about as well.
Yeah, absolutely. And to put some numbers to what you guys just discussed, it sounds like over 90% of safety net centers today have difficulty accessing specialists, And in addition, for certain specialists, that can be a wait time of up to a year for some of these patients, which is just mind-boggling, really. And then with respect to your point about double documentation and really all of the time that's burdened with the electronic medical record that's over there, it's interesting because my understanding, and correct me if I'm wrong, is that over 50% of physicians now are burnt out because of all of this kind of legal and regulatory and billing paperwork they have to fill out. They just don't get to spend as much time with patients. Is that accurate?
Yeah, I think so. It's sobering data, but we spend a lot of time in meetings, and I think this is the theme of the moment in medical education, but not just in medical education, in clinical practice. Healthcare leaders are figuring out how can we restore wellness and resilience to our healthcare professionals so they can provide the best care for patients. And so that's why a solution that would enable them that's also fun, right? You want to make learning fun. The last thing that I want to do as a medical educator is shackle somebody down and have them listen to a boring lecture, So we have to really think about what we're doing, and there's got to be better ways than we're currently doing for us to bounce cases off of each other, provide that care, and learn and document at the same time.
And I'm sorry.
Oh, sorry,
so
please.
I do think that the collaborative nature of this technology really would help lift the spirits of many of the doctors that work in the safety net. To have somebody back you up in a tough situation. As a primary care provider, I'm always, every day there is a case that I may not be completely stumped, but what if I could just curbside consult, Dr. Aurora on a case? And just giving us that sense of security and support to know that we're doing the right thing for the patient and doing it in a team-based fashion would really help, not only the patient but the providers. And what you said about the burnout rate of 50%, that 50% rate is now creeping up to 55, 60% in some specialties, especially in primary care and emergency medicine, and that's very concerning. And we do need to do something about that.
I'd love for both of you to potentially talk about, particularly Seiji, since you've worked in the safety net, you continue to, which is fantastic. Give me an example of maybe a patient or two that had a problem like that maybe you could have helped with a tool like HumanDX to actually enable them to get access in a situation where they otherwise couldn't. I'll provide some context and say that in 2015, 11 million people went into poverty because of their out-of-pocket healthcare expenses. So really often people are making the decision between either going into poverty by paying for care they might need or delaying necessary care and getting sicker. So this is really a tremendous problem. More than 30% of those situations are ones I've heard can actually be, from the most recent data, can actually be essentially resolved by a primary care physician working with a specialist online and getting that input. And then the exciting thing is that in addition to helping that 30% of people who may not need to have actually, also incurred the cost of seeing a specialist, you can then reallocate that specialist capacity and dramatically reduce wait times for the other percentage of people who actually need that care. So I'd love on the first, from your perspective, kind of an example of the first, maybe a situation where you could have helped.
Sure. There's lots of situations like that. And let me give you a couple of examples. The first is that, so rheumatological disorders, for example, are very complex. There are many, many different diagnoses that require a number of different tests and then very complex treatment regimens. And for a patient who is uninsured, and I have many uninsured patients, for example, I had this one patient who had a constellation of arthritis and rash. And none of these constellation of symptoms matched exactly what, a classic diagnosis of rheumatoid arthritis or Sjogren's disease or something that you see in a textbook.
Right.
In those kind of situations, you would love to be able to consult a specialist to tell me, hey, in this kind of tricky situation, what would you have done? And especially in this patient's case, I can't just order a battery of tests because they can't afford it. Mm-hmm. And so, what are the most important tests? Right. And in the meantime, are there treatments that I can offer? If I can just consult a specialist virtually, right, that would have saved the patient lots of money. It would have saved me time as well as my anxiety of not being able to do something for the patient.
Well, Vinny, one thing that I'd love to talk to you about really briefly is, Seiji just mentioned how this problem is dealt with in the safety net, and of course there's a major gap there which we're hoping to help serve. Since we're here at University of Chicago Medical Center, a world-class academic medical center, it'd be great to hear how this problem manifests in your day-to-day practice and how you solve it as kind of a truly world-class institution.
Yeah, well, as a hospitalist, we're on the receiving end, receiving patients in the community who have very complex problems, and I would say by and large, a lot of that care and procedures, intensive stuff does need to be done here. But at times, what you see, I'll just recollect a recent case. I was able to see a patient here who had been grappling with an unknown disease for 3 years, okay?
Wow.
And at the same time, he was not able to work. he had basically gone on disability. His wife was already disabled. I mean, this was really crippling their family, and they had to get hospitalized here from out of state, and so it was a huge ordeal for them. We were ultimately able to make the diagnosis, which was great, and it was actually a rheumatologic condition. But at the same time, if you look at his chart, there was massive amounts of workup being done. But one thing that really struck me is, as I was reading the notes that were transferred here, was that his primary care physicians in the community said something like, unclear what it is, awaiting input from specialists, have placed referrals into X, Y, and Z, waiting back. And you really felt the pain of the primary care physician in the community. And so I think that that's something that we could have helped this person earlier, right? Because when I bounced this case off of multiple specialists here, we were able to put our heads together, like you mentioned, and come up with the right diagnosis. But maybe we could have helped our patient earlier, and actually to the, much years earlier, and before he ended up in the situation he's in. Fortunately, he's doing okay. But think about how many patients are like that out there. And the last thing that I wanted to mention is that we also see a lot of patients who come here for specialty care, and our goal is to return them to their community, right? And so I do think we always want to return them to their community, because that's the benefit to them. It's closer to them, they already have a bond with their primary care physician, and that keeps us open for the next tertiary care referral issue that might come in, because you see a lot of academic health centers are facing large census and bed crunches and things like that. And so one of the things to kind of keep in mind is that what we want to do is have be able to offer our resources in the most efficient way possible. And that's where helping doctors in their local communities help their patients actually get better is a huge win for us.
Absolutely. In closing, I'd just love either of you to offer any final thoughts. In particular, now kind of pulling back up, we've kind of talked a lot about how this would help you in your practice, and particularly here in the U.S. Empower Specialist Care. Do either of you have any thoughts about the broader project and perhaps how it could ultimately help all of humankind?
Yeah. So I'll just start. In closing, I was in a conversation with a nationally renowned health policy leader, and he had mentioned, when we were talking about Human DX, he had mentioned there are very few technologies and initiatives that actually can speak to the triple lane of better care, of better population health at lower cost. And he said that this is it. Human DX is that type of technology and project that really could bend the cost curve at the same time improve quality.
Fantastic.
And I'll actually just piggyback on what Seiji said and say that I actually think it can go further to address the quadruple aim, because in medical education we view ourselves also as stewards of really our clinician engagement and their wellness. And I think that when I think about bringing doctors and healthcare professionals together to talk about cases, to problem solve, and to bring their best expertise to play to help a patient, whether or not they're in front of you or in front of somebody worlds away, I still think that that's really what the heart of medicine is about, and that could restore joy in practice.
Thank you both so much. Vinny in particular, thank you so much for joining us here at the University of Chicago Medical Center. We really appreciate you hosting us, and that's it from our end.